Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Dr. Kwan, thank you so much for joining us today on the Cold Steel Podcast. It's really an honor and a pleasure to have you on this show. Thank you so much again for taking time out of your busy schedule.
Thank you so much for having me. I feel very fortunate as a general internist to be a guest on your show. I'm having a lot of imposter syndrome right now. I have to disclose that the last time that I was in the OR was my third year of medical school, and I was asked to retract something that I certainly was doing a subpar job on. So I feel very lucky to be here. So thank you.
We're lucky to actually have one of the smart doctors on our show instead of just another surgeon. So thank you again for joining us. Can you tell us a little bit about where you did your training and where you grew up?
Yeah, no, for sure. So I am proudly from Scarborough, Ontario. I trained in Toronto. So I did my medical school and my residency at U of T. I completed a master's in public health at Harvard, focusing on quality improvement and patient safety. And early in my faculty appointment, I completed a fellowship in diagnostic excellence with the International Society to Improve Diagnosis in Medicine. Currently, I'm an academic general internist and I practice at Mount Sinai Hospital in Toronto. Clinically, you can find me on the clinical teaching unit on the wards, as well as on the medical consult service, where I get the opportunity to interact with surgeons such as yourself. And I also do some perioperative medicine clinics too. My scholarly work focuses on two things. So the first is diagnostic safety. So really excited to talk about that today. And my second area of focus looks at clinical informatics, decision support tools, and how we can leverage the electronic health record to improve patient care.
Fantastic. Congratulations on that journey, and obviously getting hired back where you trained is a big honor, especially in a place like Sinai in Toronto. So congratulations.
Oh, yeah. Thank you.
Yeah. Talk to us a little bit about this fellowship that you did, because that sounds like a really unique opportunity.
Yeah, I was really lucky. I actually stumbled upon this diagnostic error journey serendipitously. I was early in terms of my clinical journey and my scholarly journey. I actually attended this conference in 2013. It was the Improving Diagnosis Conference that's put on by the Society to Improve Diagnosis in Medicine, and just fell in love with the field, actually. The year later, they actually had an inaugural fellowship in this area. And the idea of the fellowship, which is actually still in its 10th iteration or something like that right now, is really to train the researchers and clinicians of tomorrow to help improve diagnosis in medicine. So it was an awesome opportunity. I had the chance to interact with some of the brightest minds in this field, some of the researchers and experts in the area, and I'm fortunate to still call them my collaborators and mentors to this day.
Yeah, that sounds fantastic. So one of the things that we wanted to talk to you about, particularly on this sort of journal club style episode that we're doing today, is about a paper that you published in the Canadian Journal of Surgery. This was in the February 2024 edition with co-authors Lisa Calder, Cara Bowman, Anna McIntyre, Richard Mimolt, Lisa Honey, Cynthia Dunn, Gary Garba, and Hardeep Singh. And I apologize if I've butchered anybody's name. But this paper is entitled Characteristics and Contributing Factors of Diagnostic Error in Surgery, Analysis of Closed Medical Legal Cases and Complaints in Canada. This was a really cool study. I think, as soon as I saw it come out in CJS, I thought this was something that we absolutely had to sit down with you and talk to you about. What was the impetus for this study?
Yeah, so again, just another serendipitous occasions. This was just a really fortunate collaboration. So about 10 years ago, Dr. Lisa Calder, who's a health services researcher and emergency room physician at the University of Ottawa, she's actually currently the CEO of the CMPA, but at the time, she was heading up their research division. And so she had invited me to join this advisory group where we were tasked with guiding the CMPA on setting an agenda for optimizing and leveraging their huge and vast database of medical legal data to improve patient care in Canada. And so I was super fortunate to be brought on as a burgeoning expert in diagnostic error. And so, over the course of this collaboration and, my experience and research in this field, I realized that there was this deficit in research in surgical diagnostic error. And so this just really turned out to be a manifestation of this concept, and is a wonderful collaboration between the CMPA and Dr. Hardeep Singh, who actually is at Baylor University in Houston and a world expert in diagnostic error. So we just kind of all put our minds together, and this paper was the fruition of that.
So to lay the ground for our discussion, and we've been talking about this a little bit, but what is diagnostic error?
Yeah, no, so that's a great question. And it's actually, as I mentioned, a topic I'm really passionate about. In its most basic form, I think you can frame it as when a diagnostic process does not go according to plan. It's when something goes wrong. So I think we know when it happens, but it's hard to name and it's hard to define. Traditionally, the framework has been a diagnosis that's either missed, delayed, or wrong. So one of those three categories. And it had been that way for many years. In 2015, the National Academy of Medicine, then it was called the Institute of Medicine, released a seminal report on improving diagnosis in medicine. And in this report, they defined diagnostic error as the failure of A, establishing an accurate and timely explanation of the patient's health problems, or B, communicating that explanation to the patient. So this definition was revolutionary at the time because it put the patient at the center of the diagnostic process and their understanding of the diagnosis. So that really changed how we thought about diagnosis and errors in diagnosis. The senior author on our paper, Dr. Hardeep Singh, has proposed a more modern definition of diagnostic error. And this takes into account the evolving nature of the diagnostic process, as you might imagine, through the natural history of as a disease might progress. As we see patients and their signs and symptoms evolve, we order tests and the results come back. Say you order that CT scan and it comes back showing a mass concerning for malignancy. You get a PET scan and it lights up in different areas. So you're concerned about metastatic disease, so on and so forth. Things change in the diagnosis. So it's in some ways you could consider it a moving target and an evolution as opposed to a binary thing. And so he proposed that we could consider diagnosis and errors in diagnosis just at a given point in time. And so you want to think about it as a missed opportunity for diagnosis. So you can pause at any given point in the diagnostic process and you ask yourself, were there missed opportunities that we could have done something differently to improve the diagnostic process? Could we have gotten that MRI sooner? Should we have ordered the MRI in a patient who had cardinal features of cauda equina syndrome so that they didn't become paralyzed? Those are the questions you can ask yourself. So each of these definitions has its pros and cons, but I think an understanding of each of them really help us to have a better and deeper understanding of the richness of this concept.
Yeah, I found that the communication to a patient piece of that being included in the diagnostic error a little bit surprising to begin with, because it wasn't something that I would typically think of as a diagnostic error, but it makes sense when you think of the fact that ultimately the patients need to know what's going on. And also if you sort of frame it from medical legal perspectives, my sense is that a lot of times when patients bring complaints, it's a sort of a fact-finding mission to try to understand what happened. What are your thoughts on that?
It's probably the most important part of defining diagnosis and diagnostic error. And that is because at the end of the day, it's the patient and their health problems, their conditions that we're trying to improve, right? Without a diagnosis, without an accurate diagnosis, we cannot have appropriate treatment downstream and improve their outcomes. If the diagnosis is incorrect, then we may be doing things that are not helpful, or at worst, they may harm the patient. And so without an appropriate and accurate diagnosis, everything downstream may be either wasted or harmful. And so that's why we need to put the patient at the center of the diagnostic process. The other thing, as you framed through at least the medical legal lens, is that when harm reaches the patient, there's lots of morbidity and mortality. So again, you asked, Why is it important that the patient needs to know, at least in a philosophical way? It's because at the end of the day, it's their body and it's their health. And if they don't understand what's happening, then we are failing as physicians and as a healthcare system to improve their health, which, as we know, in the traditional biopsychosocial model of medicine that we learned in our first day of medical school, it's not just about the body, but it's really the complete package.
Yeah, I think that's a really powerful piece of that I think opened my eyes a little bit reading your paper to understand that aspect of diagnostic errors. I think that's such a valuable thing to know and understand. We've talked a little bit about the CMPA. We do have an international audience. So for our listeners who don't know what the CMPA is, you drew upon the CMPA's database. What is the CMPA and what's sort of their role in Canada?
So as many of your listeners will know, if you practice in Canada, you likely are covered by the CMPA. So it is the primary malpractice insurance provider for Canadian physicians, and it actually represents more than 95% of all doctors practicing in Canada. So technically, it's called a national not-for-profit mutual defense organization. And essentially, physicians can voluntarily contact the CMPA at any time for medical legal advice, however big or small. I can personally attest to calling the CMPA for queries over the years and have always found their advice to be helpful. Just to provide a sense of scope and numbers, so physician advisors answer more than 24,000 calls and queries annually from Canadian doctors. And what's really neat and what I think helps shapes our understanding of the data that we're going to talk about today and the database that is so rich is that each of these calls, the data from these contacts are all collected, they are anonymized, and they are coded by a team of expert nurse analysts and subsequently analyzed by a team of statisticians and researchers. And so, previously, you may recall the CMPA has always sent us really helpful information in terms of ways that we can improve our practice. They have a very large CME component where physicians can, register for courses online to improve their practice. And currently, they're also now leveraging this data to publish peer-reviewed papers in order to further disseminate this information.
Well, that's really interesting. Is there any downsides or any potential errors in that database, or is it considered quite accurate? And also, is it public in terms of access?
Yeah, no, that's a great question. I can certainly speak as a physician who's interacted with the CMPA, but obviously the finer details I may have to leave for them to answer. But I can say in general, I think that the benefits and pitfalls of medical legal data in general still hold true for the CMPA. So as you might expect, because these are cases that were brought to either legal action or complaints, they may bias towards cases that have a higher degree of morbidity, mortality, and patient harm. So we always have to take that with a grain of salt. It may not be representative of, patients at a population level. But having said that, medical legal data has always been helpful in the study of patient safety. And that's because of the exact reason that we said is also the negative. And that's because it does disproportionately reflect significant patient harm. And so you can use that data and look at information through that lens to better understand how we can improve processes to reduce such harm.
We'll talk about it a little bit more when we talk about the results of your paper, but these were patients that were really pretty significantly impacted by the errors that happened to them. So for the papers that were included in your paper and in this database, these were all cases where they actually went to a formal review process, or did these include all complaints? What were sort of the cases that actually were included in this database?
Yeah, so as I mentioned, the CMPA takes calls from all physicians who are members of the CMPA, which reflect 95% of Canadian doctors. But in our particular study, we needed cases to have met two criteria. So the first is that it involved either a threatened or realized legal civil action. So you could either have threatened civil action or actually have gone to court that's realized. Or you could have been a complaint that was brought to a physician regulatory authority. So in Ontario, that's the College of Physicians and Surgeons of Ontario. In Alberta, that's the CPSA, so on and so forth. or complaints that were brought to the hospital formally that closed between 2014 and 2018. So that's the first criterion. And the second is cases that involved a diagnostic error that was assigned to a surgeon. And this was determined by peer expert review. So what's a peer expert? It's a physician, generally with a similar level of training and experience, who reviewed the case materials and deemed the case to be a diagnostic error. So if you met those criteria, that case was included in our cohort.
That's interesting. So can you walk our listeners who may have not read the paper in detail what your primary and secondary outcomes were and how you sort of methodologically structured your study?
Essentially, as we already touched upon, we performed a retrospective analysis of closed medical legal cases and complaints using our CMPA database. And we included cases that were either involving legal action or complaints, and that they had to close between 2014 and 2018, and they involved error as assigned by a peer expert reviewer to a surgeon. Our primary outcomes were diagnosis by surgical phase of care, so preoperative, intraoperative, or postoperative. And then the second also is using a validated framework. We looked at the contributing factors that were associated with the error, and this was coded at the level of either the provider, the healthcare team, or the healthcare system at large. And thirdly, we also looked at degree of patient harm. Our secondary outcomes included things like clinical setting, physician characteristics, patient characteristics, as well as the type of medical legal matter. So whether it was legal action versus a complaint.
Gotcha. And then if you don't mind, what was the broad overview of what you found, sort of the take-home messages? And I'm curious in particular, we're curious what the impact on patients of the particular errors would be, sort of in a broad sweep.
Yeah, so I'm very happy to. So overall, we identified 387 surgical cases that involved a diagnostic error. And just to give you a sense of what that is in terms of surgical medical legal cases overall, this represented 16% of surgical medical legal cases that also closed over the study period, so between 2014 and 2018. The surgical specialties that were most often associated with diagnostic error were general surgery, gynecology, so we excluded obstetrical care because that's a whole different can of worms, and orthopedic surgery. But actually, most surgical specialties were represented. So everything you can think of: urology, plastics, neurosurge, opto, ENT, cardiac surgery, so on and so forth. So broadly speaking, all surgical specialties were affected, and they involved each of the phases of care. So the preoperative, intraoperative, postoperative phases of care.
Could you comment a little bit about the impact on patients? Like, I think that's an important thing, like a big take-home message I took at least from the paper is how significantly these patients were impacted.
Yeah, so in our data, we showed that more than half of the patients involved in surgical diagnostic error experienced at least moderate harm, and 1 in 7 resulted in death. But I think we also have to take a step back and think about the harm that is not represented in the data. So these are cases that have resulted, as we commented on, in legal action or a college or hospital complaint. So in addition to our traditional morbidity and mortality paradigm, there's also the psychological harm to the patient and their families, as well as potential financial consequences, which you might think might be less of a case in our single payer environment than, say, compared to the US. But there's also lost income to the patients themselves and to their caregivers. So really broadly speaking, a very kind of high harm environment in these cases.
Yeah, that totally makes sense. And it's all of us, I think, as surgeons can resonate with this fact that if something goes wrong, this is not a small deal. This really impacts patients' lives. So we wanted to just go category by category here. Pretty powerful, some of the examples that are listed in the paper as examples of diagnostic errors. So we want to just start with the preoperative phase. And some of the examples really kind of struck you, both because they seemed on the one hand egregious, but on the other hand, you could totally see them happening. For example, failure to review imaging leading to only partial removal of a tumor. Or surgery was performed on a high-risk patient without awaiting pathology findings and resulting in unnecessary surgery and harm. We'll disclose to you on air that we're obsessed with sort of cognitive errors, cognitive biases on the podcast. We've done lots of episodes kind of exploring that in various ways. So we're very interested on the podcast and on what makes surgeons and human beings tick and think. So we're interested in, what do you think were some of the cognitive errors or processes that led to some of these preoperative diagnostic errors?
Yeah, sure. I think, why don't I address it as two separate things? So first, we'll talk about kind of the preoperative phase, and I'd love to delve in more into the cognitive piece afterwards. I think it warrants a whole separate conversation. It's actually one of my particular areas of interest, especially as someone passionate about diagnosis. You might think that all of diagnosis happens in our cerebral cortex, but the research actually shows that there's a whole bunch of other factors. So we should definitely get into that. But talking about the preoperative phase, so what were the most common diagnostic errors? So the most common in the pre-op phase was cancer. So most frequently lung cancer and sarcoma. And I'll give the listeners a few examples, because as you said, it is the clinical cases that are the most powerful and resonate to readers. But an example of such a case was the failure to appreciate a patient's changing symptoms between the initial diagnosis of lipoma and the subsequent surgery. And so this resulted in a failure to perform a biopsy preoperatively, leading to a delayed diagnosis of leiomyosarcoma. Another such case was the failure to review pre-op imaging, as you mentioned, leading to only partial removal of a tumor and a delayed diagnosis of invasive bladder cancer. Let's talk a little bit more about the cognitive stuff. In terms of the cognitive stuff, I think what's interesting and relevant, in particular to surgeons, is that as surgeons, you require a very unique skill set. So the question I think you've asked yourself is it something specific to surgeons, or is it something that's just kind of general and generally applicable to all physicians? But I think what's really neat about surgeons is that you often require the ability to make rapid split-second decisions that save the patient's life or limb, right? And all this, although this skill set serves you extremely well, this is a well-honed skill that you must have. It's also this exact skill set, so this automatic thinking. So if you think about it in the dual process theory, it's the type 1 thinking, you're thinking fast as opposed to thinking slow. It's this type of thinking that's most prone to faulty heuristics and cognitive errors. So I think for surgeons, there is something a little bit different about the cognitive piece that may be different from clinicians who don't need to make these rapid decisions.
That's super interesting. And, we can barely get through an episode on cold steel without invoking Danny Kahneman's name. We're veering off a little bit from the journal episode, but I think this is important. Do you have any suggestions from all the work that you've done in diagnostic errors and how to actually get yourself out of that type 1 thinking, or at least sort of figure out a way to push yourself into type 2 thinking? When I was reading these examples in the paper, I could totally see myself in like a busy clinic when you have, 30 patients to see, and you don't really, and that's where the problems happen, because you are suddenly then, for example, in the operating room, or you're sitting there in the holding area and you're looking at something again and you're thinking, what was I thinking at that time? Or I wonder if I could have approached this a little differently, or, I might have approached this a little bit differently if I had thought about this the way I'm thinking about it now. So do you have any tips for someone to kind of break out of that type 1 thinking?
It's $1 million question. I don't know if I have any very particular tips, and the reason for that is actually the explanation about that. So let's talk first about the paper, but our underlying data from this paper cannot give us a window into this deeper understanding of cognitive errors and diagnostic error, obviously. But broadly speaking, as we touched upon, lots of different cognitive errors that actually have been studied widely. So not just inside of medicine, but outside of medicine. So I think all of our listeners are familiar with things like anchoring bias, premature closure, so on and so forth. But what's interesting in the literature, so this is neat for diagnostic error, is that it now suggests that recognition of such cognitive error. So what you pointed out right now, the idea of so-called metacognition or cognitive debiasing, so what they call thinking about thinking, you pause and say, hey, am I anchoring here right now? Does that actually improve patient care? And actually, the literature suggests that it does. doesn't. It does not improve patient outcomes. And actually, the author, Catherine Schultz, I think summarized it really well. She said, being wrong feels exactly the same as being right up until the moment you realize it. So, by the time you figured it out, it's probably too late. What can we actually do? So here's the tip, I guess. There are some recent experimental studies that show that knowledge remains the key determinant of diagnostic accuracy. So I'll give you an example from internal medicine, and I always say this one, and it garners a lot of laughs, but if you don't know HLH, you don't know what hemophagocytic lymphohistiocytosis is, you cannot debias your way into diagnosing it. So if you don't know it, you can think about thinking as much as you want, you're not going to diagnose it. And I think this does speak to broader interventions to try and improve diagnosis. And that's really, education and knowledge being paramount to improving our diagnostic skills over time.
That's really, really interesting. I think one of the things that sort of struck both Amir and I, and I'm sure lots of readers of your paper in particular, was the 16% rate of retention of foreign bodies. If you ask a layman about medical error, surgical error, that's often the example that they come up with. But I think the bias, certainly amongst the surgical community, would sort of be the opposite, that rate is really, really excessively low. I'm curious if you could just talk a little bit about that particular error specifically.
As we have discussed now, this is definitely a cohort that is biased towards kind of a high harm environment. And I guess you have to recall that despite these errors being so-called zero events, this particular cohort is biased towards, specific cases. They had to have been brought forward to the CMPA and resulted in legal action or college or hospital complaint. But I do think that there is a learning point here. People often think these should be zero events, but I think this data, including other data that you've mentioned, emphasizes that it still occurs. So even though it occurs rarely, we still need to continue naming them as such. We have to call them zero events in order for our patient safety efforts to continue persisting in these domains. So another example in the surgical field might be wrong-sided surgery. People might think that's ludicrous, but that obviously still happens. So we have to call them zero events so that we can have a laser focus on bringing those rates down to zero.
Yeah, couldn't agree with you more. I think your paper is powerful from that perspective too, just to say that can't be laissez-faire or nonchalant about these things. These things still happen. The post-operative errors were also really interesting. And I think, correct me if I'm wrong, but I think that was the most common area where surgeons broke down in terms of diagnostic errors. Can you talk to us a little bit about some of the common post-operative errors? And maybe, to me, one of the things that I felt like when I was reading these is that there's a certain element of denial, maybe by the primary surgeon, that no, there's no way they could have leaked, or there's no way this could have actually happened. I'm curious what your thoughts are on that piece of it.
Yeah, so I think what's interesting about the post-operative phase is that it really does involve different areas of practice. So there's the immediate post-operative phase where oftentimes they're still in hospital, admitted. And then there's actually the more delayed kind of post-operative phase where you're seeing them in the ambulatory setting. So I think the data reflects the degree to which surgical practice can be extremely diverse. The most frequent diagnostic error in the postoperative phase involved complications secondary to surgical injury. So these included failure to recognize a subsequent clinical deterioration. So I'll give you a case example, so right from the files. But such a case was the failure to appreciate a patient's ongoing hypotension and tachycardia. So clearly in SIRS, but led to a delayed imaging and thus a delayed diagnosis of perforation of uterus and sigmoid colon, resulting in the patient's septic shock. Other common complications in the post-op phase were GI complications. So a delayed diagnosis of, say, a bowel perforation or gastric necrosis, and this led to a failure to expedite urgent surgery. Another common one, and really speaks to kind of all the phases of surgical care, is in the ambulatory setting. So it's the progression or persistence of cancer. Basically, in the case, there was a failure to order follow-up imaging at 6 to 12 months, and this resulted in a delayed diagnosis of metastatic cancer.
the concept that a lot of these errors, the vast majority, are really attributable or fall upon the medical provider or the surgical provider, i.e., the surgeon, for example. And it's interesting to think about that for those of us that have worked in, for example, both the Canadian and American system. And my overall bias would be, again, having worked extensively in both, that you see a lot more support, or you feel a lot more support on the American side of things with maybe auxiliary healthcare workers, nurse practitioners, clinical associates, PAs. There's a lot more people in the mix to try and support that patient and prevent, honestly, a lot of the errors that can happen when you compare your practice to a solo, maybe Canadian physician who's seeing an equal volume of patients without all that support. And it sort of lends my bias to thinking about the system itself and how that interplay between system support and an individual clinician plays back and forth, and what that impact on truly who's at fault should be. I'm just curious what your thoughts are on that whole concept at 30,000 feet in terms of really who at the end of the day is attributable to the error and the problem.
That's a great observation, and it's one that's certainly not lost on me. And I will say, I don't think that they are necessarily opposing issues or concepts that are discordant with each other. So as we know from the patient safety literature, so medical errors, so whether they're diagnostic errors, medication errors, anything, they can occur at any level. So at the level of the provider, the healthcare team, the healthcare system as a whole. And in fact, the root causes of these errors, often when they do a deep dive into it, are often found to be multifactorial. And, I think you had alluded to this concept of just culture. And that's where we strive not to blame and shame individuals, but rather to come up with solutions to such problems that are systems-based, because at the end of the day, oftentimes, as you mentioned, it's possibly the design of the system, the constraint of the system that leads to individual performance. And so that's why it's a systems-based approach that's often recommended in these cases. There can be systems-based solutions to these provider-level issues that we've pointed out in the paper. So I'll give you an example, and actually drawn from the surgical experience. But right now, there are interventions for diagnostic error that are being recommended, such as diagnostic timeouts rather than surgical timeouts, or diagnostic checklists as opposed to surgical checklists. And it's really very much the same thing. When you're going through a diagnostic process, you might want to take a step back and pause and ask yourself, is there anything that I'm missing? And you want to do this systematically, right? Not when you feel necessarily like things are going wrong, because we talked about you don't know you're wrong until you're actually wrong. But you can ask yourself, is there anything I'm missing? Is there anything life-threatening that I haven't considered or ruled out? The classic example for that is PE. I always kind of make a joke of things, but if every CTPA that you're ordering is positive for PE, you're probably not ordering enough scans because you're just waiting for it and you've probably been too late. So always thinking about the life-threatening diagnosis and making sure that you've either ruled them in or ruled them out. And then using a more systems-based approach to things. So, the mnemonics that we've all learned in medical school, I like to use Vindicate still to this day, but you want to ensure that your differential diagnosis is complete and you've gone through things in a systematic level. That's a systems-based approach to a personal cognitive issue, or our biases in terms of our cognitive processes. And additionally, as we also pointed out, since education and knowledge is key, that is certainly something that can be deployed and enhanced at a systems level to improve our diagnostic skill making, or our diagnostic skills. So, and basically to summarize, I don't think they're necessarily at opposition to each other, but actually because they interface so well, we can think of broader solutions to an individual issue.
Yeah, it's not either or. There's a interplay between these two things. And I'm going to remember your line about you can't debias yourself into a diagnosis of HLH. I'm going to remember that, even though I have no idea what HLH is anymore. This has been an absolutely fascinating conversation, and really, again, thank you very much for the paper and for making the time to speak with us about it. If there were a few main takeaways that you wanted readers and particularly surgeons to walk away from the paper with? What would those main takeaways be?
So I would say the main take-home point of our study is that diagnostic error does happen in surgery. It does not only happen in non-surgical disciplines. Furthermore, they happen in all phases of surgical care, so pre-op, intra-op, post-op, and that the contributing factors are commonly attributed to the provider clinical decision-making and communication breakdown. And I think that this truly brings to the forefront diagnostic safety as an important element in surgical patient safety, and that we should be looking at ways of improving our clinical decision making and communication. As I was conducting this study, it really made me reflect on, what patient safety interventions, so general patient safety interventions, are relevant to the surgical discipline? And are there interventions that may be unique to the practice of surgical care that would be needed to really move the needle on it? So I'll give you an example of a general patient safety intervention to improve communication. You may be aware of the iPass tool that was published in the New England Journal of Medicine, but it's a tool intended to improve handoff between clinical teams, and it was shown to improve patient outcomes. So the question is such an intervention adequate for the surgical setting, or because of some of the unique nature of what you guys do, is something else very specific to surgeons needed? And I think that's the next frontier in terms of the needs for future study in this area. So it's not just the generic, additional research is needed, but truly additional research is needed because it is such a unique practice. And the idea is, do we need something different, or can we just kind of do the generic patient safety stuff and hopefully things will improve? Or is it a bit of both? And I think it's probably the answer, but we should probably disentangle that.
Well, thank you so much for that, Janice. It makes so much sense, and it's such great advice. We've been so pleased to have you on the podcast. As Amir said, one of the things we do at the end of every podcast, as you may know, is ask our guests a specific question. And that question really is, if you could go back and talk to yourself or advise yourself as a younger clinician or researcher or whatever field a given person's in, what advice would you give yourself going forward? And how do you think that would change your practice and your life moving forward?
That's a great question. I'm actually often asked this when I'm interacting with my trainees. So very fortunate to have reflected on this before. And I always say the two things because these are two things that I firmly believe are true. The first is that the practice of medicine, it's not a sprint. It's not even a 5K or a 10K. It's truly a marathon. And so really recognizing that there are different phases in our career and that there are different phases of our personal life, we need to pace ourselves because the successes and failures that we may find early in our career, those are specific to them. And, we may be focusing more attention on, for example, our family life at a given point in our time. And that may make our career suffer, but that's not to say that things may change over time and that there really is room, hopefully, for successes in every domain in our career and in our life, but perhaps not always at the same time, but that's okay too, because this is a long journey that we are so fortunate to be on. And so just to really settle into the ride, enjoy it, be happy, and just be grateful for the joy that we have of taking care of patients and hopefully making feel better. And the other thing I often say, which I've reflected on it so much myself, but in medicine, we are so trained to be goal-oriented. It obviously selects for a certain type of personality. But I think we train ourselves to have this deferred gratification. When I'm finished med school and I match in CARMs, things are going to be so great. But then you speak to residents and they say, once I get that job, things are going to be great. But you talk to early career faculty and they say, once I get my grant and things settle down, things are going to be great. But actually, if you think about it, in all those phases, as we talked about, things are great. It's often just a matter of perspective. And so I have to remind myself that too. And so it's often helpful to remind our peers around us, because really we're so lucky to practice medicine. And so, let's not defer our gratitude. Let's just be happy right now.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.